welcome to this month's podcast, where, as always, we're going to bring you up to date with the latest information and data today in the world of rheumatoid arthritis. And I'm particularly excited because today I am joined by Professor Janet Pope and Dr. Sofia Ramiro. Janet is Professor of Medicine at the University of Western Ontario, Schulich School of Medicine, and Sofia is a consultant rheumatologist and senior researcher at the Leiden University Medical Centre. I am in the presence of greatness, folks, and I'm thoroughly looking forward to having a jolly good conversation with my dear friends and colleagues, Janet and Sofia. Young ladies, would you like to say hello as well?
Hi, everyone. Thanks for listening.
Of course, welcome everyone, and it's very nice to be here all together and discussing this exciting topic today.
Fantastic. Well, listen, I'm really looking forward. We've got a couple of really interesting papers here. The first is from Buch and colleagues who examined the extended MACE endpoints with tofacitinib versus TNFi. And our second paper comes from my other dear friend, Gerd Burmester, and his colleagues who present the long-term efficacy and safety of data for upadacitinib now through 5 years. And as always, if you want to access summary slides, details, and other really incredibly useful background information, head across to imidforum.com, imidforum, all one word.com. So look, without further ado, Janet, I'm going to ask you to talk about the first paper, which of course concerns the issue of safety and particularly cardiovascular events in JAK inhibition and TNF inhibition. So over to you, Janet. Thanks.
Okay, great. Thanks, Ian. So this is a new analysis, so exploratory, of the oral surveillance. So unless if you had some kind of sleeping sickness and were in a coma for the last few years, if you are in the rheumatology sphere, you know about oral surveillance. However, in brief, I'll tell you 3 sentences on it. So oral surveillance was mandated by regulatory bodies to look at cardiovascular safety and malignancy in JAK inhibitor, tofacitinib, at the 2 doses, 5 milligrams twice a day, our only approved dose, and 10 milligrams twice a day, not approved, versus usual TNF inhibitors. Some countries etanercept, some countries adalimumab. It was in patients who were over a certain age, so over an age where you're going to think of cardiovascular events occurring. They had to have 1 or more cardiovascular risk factors. They also had to have things such as high disease activity, of course, to go on this study, methotrexate, inadequate responders, and they were all on background methotrexate. It was randomized to the 1-to-1-to-1 to the 3 groups. The 10 BID group eventually was stopped due to increased pulmonary emboli, some increased other adverse events, and then they just rolled over into the 5 milligrams twice a day, and all patients randomized were analyzed, of course, in the group that they had started in. So that, and it was event driven for cardiovascular events. So if we all remember, there were more malignancies, barely, but truly statistically more, but also numerically more, of course, on tofacitinib in the combined arms. And the other co-primary endpoint, which we're going to discuss in more detail now, was that basically the bottom line was there was numerically slightly more events in tofacitinib compared to the TNF inhibitor group, but that the confidence interval was exceeded. So it went from could have been protective, probably not, to no increased risk, to numerically a higher risk, to a confidence interval where the confidence interval went beyond what was agreed upon. So it was kind of a failed trial in that we can't say it wasn't non-inferior. And it certainly wasn't. So it was one of those, wrap your head around those words, but basically we couldn't really tell what was going on, but numerically more on both of the co-primary endpoints and the tofacitinib group. So what did these folks do? So basically this would have been a Pfizer-sponsored study to do an exploratory analysis. And I'm not going to get you into the weeds, but the bottom line is they looked at different definitions of cardiovascular risk. And the cardiovascular risk, they basically said, let's look at whether you had cardiovascular death. So fortunately, very uncommon and not different in both groups. MI, non-fatal, and stroke. And that was MACE 3. Then they started adding things, and hospitalization for unstable angina, and coronary revascularization. So that's MACE 4, MACE 5, and a TIA, et cetera. And they went down to congestive heart failure and also adding in VTEs. So If you want to change a risk a little bit, you can add things that are uncommon and see if it changes, or you can add common things we're worried about. That in this study, all the events were pretty uncommon despite having a high risk group with more hypertension, diabetes, and other risks than hyperlipidemia than our usual RCTs and RA. So the first thing is, if you look at the very strict endpoints, statistically no difference. This was exploratory, but numerically slightly higher in tofacitinib, as we would expect, because they MACE 3 and 4 are very close to the primary endpoints, which were numerically higher in tofacitinib in the original study, but not statistically. And then the most important thing, I think, and if people are looking at the papers, are looking at if you see patients who have had a previous cardiovascular risk, a cardiovascular event, yes or no. The most important part of the paper is if you have a history of atherosclerotic cardiovascular disease events, you will be very high on your event rate compared to, within the study, no cardiovascular events. So if you have risk factors, they alone are not as high as having had a previous event, which is kind of logical. So no history of ASCVD, the atherosclerotic cardiovascular disease, no difference between the two TOFA arms, and TNF, the graphs are low rates, look all virtually identical to my eyes. If, however, you've had a history of events, all the event rates go up, and a little bit higher. You start with just a slightly higher slope, and then kind of in parallel if you're on TOFA 5 or 10 milligrams twice a day. The other important take home is that they didn't see any difference in congestive heart failure, new or worsening, and that's not a high problem in our patients with coronary artery disease at the mean age from this paper, but I think that was reassuring too. Bottom line, this is a hypothesis generating and not testing study, and it doesn't change what the original conclusions were, but it gives us more insights.
Fantastic. Sofia, when you looked at the paper, what struck you?
I think, thank you very much, Janet, for this fantastic overview. And I think that it's important to see again, of course, it's the analysis within the same trial, but we always see the same data, that having had a previous event is really what determines most the risk. So having had an atherosclerotic event really determines the risk. And there we see a separation between patients with the JAK inhibitor, so tofacitinib, and TNF inhibitor. We also see the same again in older patients and younger patients. So I think that, of course, all the analyses within the same trial are giving the same results, but on the other hand, it's reassuring to see that this every time. Of course, when we go in subgroups, we have to be careful because it's no longer randomized to make these comparisons. We are going into smaller groups, so we don't have power to make those comparisons. We all know that, but it's never too much to emphasize these methodological challenges, I think. But on the other hand, it's very unlikely we will have another oral surveillance. So we have to do as much as we can to learn as much as possible from this, and to stratify the risk for our patients, to know better who are the patients in whom the risk it does not seem to be there. And then when we have younger patients and non-smokers, patients without a previous atherosclerotic event, we really do not see a risk there. So I think that's good to know and reassuring to know.
And I think it has face validity, right? We would be very concerned if there were big differences in low-risk patients. I think we'd have huge concern because the event rate would be low. You could kind of not find the events maybe as much, like, because they'd be smaller. But I think it just has face validity of anything. The most likely you are to have cardiovascular events is having had them.
Yeah, Janet, I think I really like the way you've formed that, and Sofia, thanks for your synthesis. I mean, one of the most important things that oral surveillance shows is that if you've got cardiovascular risk factors or a past history of an event, you're more likely to have another one. And the second major learning for me was how undertreated the cardiovascular risk was in this population with rheumatoid arthritis, which in this day and age, as someone who's been talking about and writing about the importance of cardiovascular morbidities. Look, I work in the west of Scotland, home of WASCOPs, highest cardiovascular rates in Western Europe. I actually I'm a bit disappointed there, and I think there's rightly, there has been huge focus around the safety issues of JAK inhibition as a class, tofacitinib as a drug. But I think at least as much concern should be shown for the apparently somewhat lower than necessary prevalence of appropriate treatment. The other thing, I guess, that came across to me when I read this was, yeah, do you agree, Janet? Yeah, I mean,
hypertension. They were undertreated, not treated in obviously smoking cessation programs. However, that, Iain, even though the events are higher in RA, interestingly, the event rate was on both group, all three groups, was far lower than the INTRACT trial, and I don't think they did it as well either. But the INTRACT trial, interestingly, didn't have to have background methotrexate. Yep. Maybe that made a difference. I'm just speculating. Maybe 10, 15 years between the two trials enrolling might have been that even some degree of hyperlipidemia, hypertension, and diabetes treatment is a little bit protective for all our RA patients on getting less events. I don't know.
Yeah, I mean that was the original Harvard study that demonstrated that, you know, methotrexate a priori is probably a reasonable way to go, possibly as a surrogate for disease activity. Interesting. Look, the final thing I was going to say here, I must say, is that it's interesting to me that MI and VTE still came through. And, you know, and if you think about mechanism, I would talk about mechanism, wouldn't I? Because I don't, not as clever as you guys in terms of trial design interpretation. But mechanistically, this is all pointing to some kind of altered clotting endothelial tissue interaction, and it's at higher dose. So look, let's watch this space. I guess, Sofia, you're right, we won't get another oral surveillance. We will have some data with baricitinib coming out at some point. And in the meantime, I commend this paper to you. It's a nice analysis. We are getting to the limit of the number of post hoc analyses of one study, though. And I think, Janet, possibly the most important thing you said there was that this should be considered hypothesis generating, but a beautiful piece of work nonetheless.
Right. And I think just one final word, absolutely, this is reassuring for prescribers that, you know, it's sort of like, I'm going to be very, you know, off the wall, surprisingly. If I'm worried about pregnancy, I don't discuss that with a 58-year-old woman. So if I'm worried about cardiovascular events with JAK inhibitor prescribing in RA or even other diseases, I really am not going to discuss that with a 32-year-old patient who's done their family. So I'm not worried about teratogenicity, et cetera. So I think we always have to, when we're prescribing, balance risk and don't throw away a class of drugs that can be quite helpful for our patients, which is probably a good segue to what Iain will tell us introduce next.
Yeah, I mean, truth is, Janet, you may or may not be aware over there in North America, but we have the European Football Championships just about to start. And it would be a waste of time talking to a Scottish supporter how it would feel if they won the championship. You know, completely and utterly useless. So you're right. If there is a highly unlikely event, probably we shouldn't be troubling our patients. Anyway, look, let's move on. We're going to talk next about a paper from Gerd and his colleagues looking at the longer-term follow-up of upadacitinib. Sofia, delighted if you could guide us through this one, please.
Sure, thank you very much. And indeed, we are going to talk about this long-term extension of SELECT NEXT study and about the 5-year data. So the SELECT NEXT was a 12-week RCT, placebo-controlled, double-blind, in which patients were randomized to placebo, upadacitinib 50 milligram or upadacitinib 30 milligram. And patients who completed the 12 weeks, then they were eligible to enter the long-term extension for up to 2 years, to 5 years, sorry, at this moment that we have data up to 5 years. Blinding continued until the dosage of upadacitinib 50 milligram was approved, which means that the earliest that it occurred was at week 168. Until then, it was blinded. And there were efficacy assessments as normal in all the trials, but here with a focus, of course, on disease activity. And the CDAI was used as the assessment of low disease activity, so a CDAI below or up to 10, and a clinical remission of a CDAI up to 2.8, as well as DAS28 and the usual ACR outcomes. Also, other outcomes were assessed, and I will go through the results of this long-term extension. There were 661 patients that were randomized, and 92% of them completed week 12, and then entered the long-term extension. And of these 611 patients, then 44% of them discontinued upadacitinib by 5 years. This is a high number of discontinuation, but it's also a long period of time, 5 years. 16% of these patients discontinued due to adverse events, 3% due to inefficacy, and in 10% of patients, there was no reason attributed, 3% were lost to follow-up, and other different reasons were given in up to 8% of the patients. And overall, approximately 40% of patients did not achieve CDAI low disease activity at week 24. And we see that the clinical outcomes improved and were maintained from week 24 throughout the 5-year period on treatment on upadacitinib. And if we look at the outcomes at 5 years, 51% at 5 years, patients randomized to UPA 15 milligram, 51% had achieved CDAI remission, and 85% had achieved CDAI low disease activity. This is as observed data, and of course, this is the challenge with the long-term extension of trials, because if we go to the other extreme, which would be the non-responder imputation, that is a very conservative method, then of course we get lower rates. So we would get a CDAI remission with 15 milligram of 27% and low disease activity, CDAI low disease activity 45%. In general, in other outcomes, namely patient-reported outcomes, including pain, function, morning stiffness, the efficacy was maintained throughout the 5-year period of treatment of upadacitinib, and long-term efficacy was comparable with patients with the one that was initially seen, and it was sustained throughout time. In terms of safety, we have already discussed a lot about safety, about the JAK inhibitors, and throughout this 5-year extension we saw that the safety profile of upadacitinib remained consistent with earlier analysis. Of course, we see more herpes zoster, for example, but that's consistent with what we would expect on JAK inhibitor. But in events like we have just discussed, malignancies, excluding non-malignant skin cancer, but MACEs and VT events, they were very infrequent in all treatment groups. So I think that in conclusion, we have here confirmation that there is sustained response to upadacitinib throughout a long period of treatment without new safety findings, as I think we were expecting. So I think it's in general good news. So open back to you, Iain.
Yeah, no, thanks, Sofia. Janet, your thoughts?
Right. So before the thought, Sofia, remind us and the listeners, what line of therapy was this? Was this CS-DMARD-IR, metho-IR, TNFi-IR?
Very good. Sorry that I did not mention that, Janet, you were right. I immediately started about select next, but indeed these are patients who are CDMARD insufficient responders. So in principle, most of the patients were biologic naive. They could have had a TNF inhibitor if it was stopped due to adverse events. So they could not have had inefficacy to a biological DMARD.
Great, and that's what I thought, but I think to clarify. So
Sure.
First of all, I'm very impressed to have a double-blind trial go on this long, because it went into long-term extension for a long time. And we usually don't see that. And usually as you go into long-term extension, you stay on what you're on because you know you're on active drug, et cetera. So, and you know which drugs. So that I was impressed that they were actually able to do that. I think what this tells me is that this is very reassuring. We don't expect to see rare events in a well-defined population who would be at most moderate risk for all sorts of things because they are actually excluded, if you know, past serious cancer, et cetera, past serious infection needing IV antibiotics within a recent time frame, you know, bad livers, bad kidneys, et cetera. So in the ideal world of very active RA going into a study like this, I think it's really extremely helpful to know that the efficacy is maintained over time, that with blinding, they were able to continue to follow these patients and not have them drop out. and that no new safety signals. So to me, it's reassuring. The other thing I think as a prescriber and for the listeners is that, again, to consider that this was a highly effective therapy in the CSD-MART-IR population, that in all lines of therapy where UPA and where the other JAKs and RA have been tested, we see high efficacy compared to whether it's placebo, methotrexate, or sometimes another active advanced agent. We see that this JAK class, or UPA, in this study is doing very nicely.
Yeah, and I would like to add, I totally agree with what you said, Janet. And to that, I would like to add that I think that it's very elegant how they analyze the data with non-responder imputation up to 5 years. So this is by far the most conservative method, and assuming that patients that are lost to follow-up are not responding, which is not always like that, or if patients are not coming to a visit. And still, I think we see good responses. We still see high responses even with non-responder imputation. So I think that's important also to emphasize.
Yeah, I mean, your comments about trial design are really well taken, Janet. I mean, I guess the patients know they're on active something because they switch from placebo. And the other thing, of course, the context of an RCT means that some of the other things that we would just do in routine practice, we don't do because we're, the patient's in test mode. So I never worry too much about we always report the number of patients in state X, Y, or Z. Actually, the ones that stagger me are the ones who aren't and yet who are still in a trial 5 years later. I've often wondered about how you can be a really marginal partial responder in 5. They must love their study nurses, but and actually, I'm not really being trite there. I think there is an issue of patients become quite affiliated in trial. But no, this is a reassuring study. Probably we don't want to overstate the value of the safety analysis here, because this, just to be clear, given the juxtaposition of a non-inferiority randomized study in terms of oral surveillance against, this is follow-up, not powered to look for events. So I think the authors have been appropriately conservative in saying we didn't see anything new. But that's different from saying that's completely reassuring. We don't need to worry about this. Janet, any thoughts you have about the class effect as opposed to more selective JAK inhibition around toxicity? It's a really unfair question, but it's more your gestalt than any, because we don't have good data yet is the answer, just to preempt it. But
right.
Just gestalt to advise the clinicians out there making that decision.
Exactly. So I'll answer that, and then I'm just going to have one more comment on what you said about patients not in low disease state who can maintain on a trial. So my gestalt on the class, I mean, first of all, for some probably very good reason that sometimes is beyond my knowledge base. TYK2s are not considered JAKs, even though they're in the JAK family and they don't have the same labeling. So who knows? So that's the first thing. So if I'm going to do a gestalt over JAK, I could say, well, TYK2s are different. So is a JAK1 different than a 1-3, different than a 2 or 2-3, or a JAK1 TYK2 or whatever. I think we will never have the data for UPA or Filgo the way we're going to have the VTE on Berry, we mentioned already, and the way we have the oral surveillance on TOFA. So with that being said and done, just think of it, there's class effects and individual effects in NSAIDs, in osteoporosis, bisphosphonates, et cetera, et cetera. So in our TNFs, there's risks of TB, and in some monoclonal high dose, it might be higher than, say, a receptor blocker. So I think we have to just go by what we have as recommendations and say, although in my mind, here's the gestalt, although there could be individual differences, I think we also have to think of JAKs as a class. So I'm kind of copping out a bit. And then just one other thing, people in the real world are happy and they don't have their drugs changed, even if they're not in trials, when they're not in low disease activity. And I think there's two things in a trial that, of course, there's an incentive to continue on in the trial. They get great care. As you say, they love their study nurses. But I think if you dissected a CDI or a DAS and the patient's continuing on treatment, that none of them would have really, really, really high swollen joint counts. And really, MD global and swollen joint counts are very important on when a physician says, get out of a study or make a treatment change.
So one of the things I love about talking to you, Janet, is when Janet speaks, you are in the presence of a supremely gifted trial designer. When you design trials, you understand what detail is hidden behind composite outcomes, and that's a really well taken remark. And the truth is that there are, and well, I mean, in fact, we know from numerous studies, probably Dutch studies, Austrian studies particularly, patients' opinions and metrologists' opinions are actually driven quite often by different things. And that, I think, will contribute. Sofia, just maybe as we draw our discussion to a close, recommendations, EULAR recommendations, and when should we be using JAK inhibitors, given just bringing the two papers together? It might be worth reminding our listeners just exactly what EULAR thought about this. And Janet, heads up, I'm going to ask you the same question about ACR in a moment. So Sofia, just a quick reminder of where we're at with JAK inhibition in terms of recommendations for rheumatoid.
Yes, I think indeed we have to take the findings of viral surveillance into account. We are not sure about a class effect, which is possible, and therefore we have to be conservative in the way we formulate our recommendations. And therefore we, at the EULAR level across all the inflammatory diseases, we put some caution and on the prescription to JAK inhibitors, particularly in the groups that we discussed before that have the higher risk for those adverse events of MACEs and malignancies. So there, I think we have to be more conservative and not, but that's also actually our recommendations, EULAR recommendations were formulated before, but then came the EMA warnings. And of course, nowadays, all clinicians also have to follow the EMA warning anyway, and the FDA ones are even stricter. So I give the word to Janet to tell us how it is in the US.
So thanks, Sofia. So in the US, what the rheumatologist thinks, what the ACR says, and what the FDA says, and what the payers do, all can be with innuendo a little bit different. So FDA is really saying consider in general, in rheumatoid arthritis at least, a TNF inhibitor before a JAK. So a JAK after with your bio-DMARD exposed, experienced incomplete responder, secondary loss of effect, whatever. What I believe that ACR is telling us is that there can and should be choice, and that you must take risk into consideration. We always want to balance benefit to risk, but let's be honest, this class is on the market. It's been around a long time. The diseases that they're getting approvals in are exploding, more and more occurring. So this class will be with us, and we have to understand how to manage risk. And circling back to what Iain said earlier, maybe the best thing that comes from us being aware of risk is to actually stratify our patients on risk and say primary care or general internist or whomever, cardiologist or ourselves, please let's get that risk down. Our patients are most apt to die of cardiovascular events and cancer like all the rest of the population, but accelerated in our patients, particularly at high risk. And if we can put that in our notes, hello, our patients with RA, active RA or at high risk, please consider traditional risk factors. And I, as a rheumatologist, will try to work on the added non-traditional risk factor of chronic inflammation.
Music to my ears, Janet, music to my ears. Well, look, I'm going to take the chair's prerogative of drawing a dotted line under our discussions. I could listen to Sofia, Janet, I could listen to you guys chatting all day. I always learn, and I know those who are listening into the podcast will want to join me in thanking you both for sharing your knowledge, sharing your insights, and actually sharing your gestalt, because that's what we treasure. So thank you both. And to those of you listening to the podcast, if you want to look at the publications uploaded this month and to access all our other podcasts and resources, yes, there's more, head over to the new imedforum.com. That's imedforum, all one word, .com. And don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel. Make sure you don't miss our podcasts in future. Chance to be a fine thing. You mustn't do that. And as always, make sure to let us know what you think by leaving a review. But most importantly, thank you so much to my learned co-presenters. Thank you to you, our listeners. We really appreciate it. We hope that you find this useful in what is, after all, the reason that we're all here, which is the better care of people with rheumatic musculoskeletal disease. Thank you. Enjoy.